The bronchopulmonary dysplasia. Definition: is a chronic lungs disorder that is most common among children who were born prematurely and those who receive prolonged mechanical ventilation to treat respiratory distress syndrome. Dysplasia means abnormal change in the structure or organization of a group of cells. The cell changes in BPD take place in the small airways and lung alveoli and causing problems with lung function. For stages 1, 2, 3, and 4 are classified based on radiological findings and associated pathological changes. Stage 1, 2 and 3 days is a period of acute RDS. The radiology pictures is similar to RDS. Stage 2, the 4 and 10 days is a period of regeneration. The chest radiograph shows complete opacity of the lungs obscuring the ear and lungs borders. Stage 3, 10 to 20 days is a period of transition to chronic disease. The radiographic changes are replaced by areas of coarse, irregular shaped densities, areas of oscillations. Areas of density are caused by interstitial edema or teletasis due to obstruction of small bronchioles with laminar debris. The cysts represent foci or emphysema. Stage 4, beyond 1 month, is a period of chronic disease. Chest radiograph shows large cysts and marked fibrosis and edema with areas of consolidation and areas of overinflammation. New criteria: male, breathing room out at 36 weeks postmenstrual age or discharge, whichever comes first. For babies born before 32 weeks, or breathing room are by 56 days postnatal age, or discharge for babies born after 32 weeks gestation. Moderate, need for less 30% oxygen and 36 weeks postmenstrual age, or discharge for babies born before 32 weeks of need for less oxygen to 56 days postnatal age, or discharge whichever comes first. And several need for more 30% oxygen with or without positive pulsus ventilation or continuous positive pulsus at 36 weeks postmenstrual age, or discharge for babies born before 32 weeks, or need for more than 30% oxygen with so positive pulsus ventilation or continuous positive pulsus and 56 days postnatal age, or discharge for babies born and after 32 weeks gestation. Pathology of bronchopulmonary dysplasia. The characteristic changes of classes BPD are airway injury and inflammation airway, epithelial cell metaplasia, and parenchymal fibrosis. Diagnosis: Iris criteria. The classic diagnosis of BPD may be assigned at 28 days of life is the following criteria are met: positive pressure ventilation during the first 2 weeks of life for a minimum of 3 days, clinical signs of abnormal respiratory function, requirements for supplemental oxygen for longer than 28 days of age to maintain PA of to above 50 mg. Chest radio with diffuse and normal findings characteristics of BPD. The treatment, the mechanical ventilation. The medicine for treating RDAs has been subsequent replacement with oxygen supplementation. Continuous positives are with pressure, CPAP. Mechanical ventilation. The treatment necessary to recruit air and prevent atelectasis in the immature lungs may cause lung injury and activates the inflammatory cascade. Trauma secondary to positive pressure ventilation is generally referred to as barotrauma. Barotrauma suggests the occurrence of lung injury secondary to excessive tidal volume from PPD.
Hello and welcome back to MRCPCS team. Today I'm going to talk briefly about the bronchopulmonary dysplasia. Guys, before starting this, once again I will request you to subscribe to my channel, tell your friends about my channel, and please go to my channel where you can find different playlists. Click once, each and every video in that topic will be played automatically. Guys, it's just kind of saving your time, like it will take you around 1 hour for neonatology, then you will revise so many topics and you will remember for a longer time because you are learning by videos, and you will be updated with the information. And if you have any updated information, please tell me, I can upload for you, and please comment on that if you know any good information about any disease which I uploaded before. Okay guys, let me start with the bronchopulmonary dysplasia. Let's give a kick start. Bronchopulmonary dysplasia is a form of chronic lung disease that develops in preterm neonates treated with oxygen and PPV. Bronchopulmonary dysplasia results from various factors that can injure small airways and that can interfere with the alveolarization, that is alveolar septation, leading to alveolar simplifications with a reduction in the overall surface area of the gas exchange. The developing pulmonary microvascular musculature can also be injured. Alveolar and lung vascular development are intimately related, and injury to one may impair the development of the other. Damage to the lung during the critical stage of the lung growth can result in clinically significant pulmonary dysfunction. Premature birth and subsequent events, exposure to oxygen, mechanical ventilation, inflammatory agents, likely shifts the balance from the lung development consisting of lung alveolar and vascular growth to one of the premature maturations, which is associated with an arrest in the development and a loss of future gas exchange area. However, the alveolar maturation might facilitate gas exchange in short terms. Infants with a bronchopulmonary dysplasia, that is a BPD, have abnormal findings on the physical examination, chest radiography, pulmonary function testing, and histological findings. Initial findings observed shortly after the birth are consistent with the respiratory distress syndrome (RDS). Persistence of these symptoms can be associated with increased risk of bronchopulmonary dysplasia. Okay guys, physical examination may reveal tachypnea, tachycardia, increased work of breathing, that is with a retraction, nasal flaring, grunting, frequent desaturation, significant weight loss during the first 10 days of the life. Infants with a severe bronchopulmonary dysplasia are often extremely immature and had very low birth weight. Their requirements for oxygen and ventilator support often increases in the first 2 weeks of the life. At 2 to 4 weeks, oxygen supplementation, ventilator support both are often increased to maintain adequate ventilation and oxygenation. The chest radiograph may demonstrate decreased lung volumes, areas of atelectasis and hyperinflation, pulmonary edema, and pulmonary interstitial emphysema. Hyperinflation or interstitial abnormalities on the chest radiograph appears to be correlated with the development of airway obstruction later in life. Okay guys, this is what about bronchopulmonary dysplasia. The most important point what you need to remember is the pathophysiology, how you diagnose. That's very important points. What is the mainstay of treatment is surfactant replacement with oxygen supplementation, continuous positive airway pressure and mechanical ventilation. Okay guys, these are the very important points what you need to know. Sorry. Chest radiograph may demonstrate decreased lung volumes, areas of atelectasis, hyperventilation, pulmonary edema, PIE, hyperinflation, intestinal abnormalities on the chest radiograph appears to be correlated with the development of airway obstruction later in the life. Okay guys, regarding the treatment options, what you need to do is supplement the oxygen to maintain oxygen saturation above 94. That's very important. Good nutrition is very important. Treating underlying factors like infection. If there is infection, treat the infection. Gastroesophageal reflux, fits, cardiac problems, you need to treat. Okay, ventilatory support is very important. Dexamethasone can be used in the treatment of bronchopulmonary dysplasia. Okay guys, this is very important topic. Just go through once. If I miss any important points, so please comment on that so that others will come to know, and even me. Okay, thank you so much for watching my video. Take care, see you soon in the next amazing awesome video with me on MRCPCH team. Okay.
Chapter 410, Bronchopulmonary Dysplasia. Stephen Lester. Bronchopulmonary dysplasia (BPD) is a syndrome characterized by signs and symptoms of chronic lung disease that originates in the neonatal period. Chapter 95. The pathogenesis of the lung disease was originally thought to arise from mechanical and oxidant injury to the airways and interstitium, leading to edema, inflammation, and fibrosis with characteristic radiographic and pathologic stages. The pathogenesis of lung disease in the population of neonates 1000 G also includes the contribution of immature development of airway and vascular structures of the lung. This fact has led to a change in recognized radiographic, pathologic, and clinical findings in BPD and an evolution in its definition. An accepted definition includes an oxygen requirement for 28 days postnatally, and the disorder is graded as mild, moderate, or severe on the basis of supplemental oxygen requirement and gestational age. See Table 410-1 on the Nelson Textbook of Pediatrics website at www.expertsconsult.com. Table 410-1. Forms of bronchopulmonary dysplasia BPD. Additional features additional features of severe BPD of all BPD, mild BPD, moderate BPD, 32 weeks postmenstrual, more than 30% supplemental oxygen at 36 WKPMA and HPMA, breathing room air, 30% supplemental mechanical support, continuous positive airway oxygen at 36 WKPMA, oxygen at 36 WKPMA, pressured CPAP, or ventilation requirement first 28 days, more than 32 weeks PMA, 30% supplemental oxygen, breathing room air oxygen at 56 days of requirement first at 56 days of life, 28 days of life, more than 30% supplemental oxygen at 56 days of life, and mechanical support, CPAP, or ventilation. Clinical manifestations. Physical findings of the pulmonary exam vary with the severity of disease. Tachypnea is a common finding. Mouth breathing due to narrowed nasal passages and high arched palate is noted on upper airway exam. The chest demonstrates an increased anteroposterior diameter that suggests air trapping. Intercostal retractions are frequently present. Although breath sounds are frequently clear when the patient is well and abnormal only during an acute exacerbation, many patients have baseline wheeze or coarse crackles. A persistent fixed wheeze or stridor suggests subglottic stenosis or large airway malacia. Fine crackles may be present in patients prone to fluid overload. The most severely affected patients require prolonged mechanical ventilation to achieve acceptable gas exchange. Supplemental oxygen may be required to maintain oxygen saturation values more than 90% and often is needed to minimize the work of breathing. Infants with significant lung disease exhibit growth failure from the elevated energy expenditure essential to maintain the increased metabolic demands of respiration. Chronic respiratory insufficiency may be evident as elevation of serum bicarbonate, elevation of PCO2 on blood gas analysis, or polycythemia. Patients must be monitored for the development of cor pulmonale, especially if they require supplemental oxygen and have chronic respiratory insufficiency. Gastroesophageal reflux disease GERD Chapter 315, and pulmonary aspiration complicate pulmonary status, particularly during an exacerbation when the infant is most tachypneic and when pulmonary mechanics increase the risk of GERD. Other conditions due to premature birth complicating BPD include upper airway obstruction leading to hypoxia, neurodevelopmental delay with increased risk of aspiration, systemic hypertension with left ventricular hypertrophy, poor growth, and the electrolyte disturbances. In severely affected patients and patients with disease out of proportion to their risk for development of chronic lung disease, other pulmonary disease must be suspected, such as asthma, cystic fibrosis, and chronic aspiration pneumonitis. Recurrent episodes of respiratory distress are common, but anatomic airway abnormalities such as subglottic stenosis and airway malacia must also be considered. A pulmonary exacerbation of BPD is typically triggered during viral upper respiratory infections. Other frequent triggers include viral lower respiratory infections, sinusitis, otitis media, weather changes, exposure to cigarette smoke, and exacerbations of gastroesophageal reflux. During an exacerbation, the infant exhibits increased work of breathing, with tachypnea and retractions becoming more prominent. Chest wall configuration may change, with an increased anteroposterior diameter. If wheezing is a prominent baseline finding, poor air entry during an exacerbation may result in less wheezing, signifying a significant deterioration of respiratory status. Treatment is aimed at decreasing the work of breathing and normalizing gas exchange, to allow for optimal growth and neurodevelopment. Infants requiring supplemental oxygen past 35 WK postmenstrual age have a higher incidence of lower airway obstruction and bronchodilator responsiveness and are more likely to be hospitalized during the toddler years than their peers. The etiology of wheezing in BPD may be lower airway inflammation, bronchial smooth muscle irritation, bronchial smooth muscle hypertrophy, and airway malacia. The administration of an inhaled bronchodilator is frequently undertaken to evaluate an individual's response. Most commonly, inhaled agonists initially increase air movement and improve comfort of breathing, resulting in short-term improvement in pulmonary function values. For patients whose disease responds, the medication should be continued, especially during high-risk periods when triggers are present, such as an upper respiratory infection or hot humid days. Agonists may worsen the air exchange, particularly in infants with BPD and concomitant airway malacia. Bronchial smooth muscle may maintain airway caliber in the affected airway. Smooth muscle relaxation after administration of agonist results in increased small airway collapse. Patients in whom agonists have these effects may benefit from alternative bronchodilators, such as inhaled ipratropium and oral methylxanthins. The administration of preventive anti-inflammatory medications such as inhaled glucocorticoids and leukotriene-modifying agents may be considered in patients with frequent inflammatory triggers. Targeted goals for supplemental oxygen therapy after discharge from the nursery are to improve oxygen saturation values and decrease likelihood of desaturation, reduce the risk of cor pulmonale, diminish the work of breathing, and improve growth. This therapy likely improves neurodevelopmental outcome and may decrease exacerbations caused by hypoxia. Oxygen saturation value should exceed 90%, but the optimal goal above this level is unknown. The addition of diuretic therapy with furosemide or thiazides may improve pulmonary mechanics by decreasing lung water and allow tapering of supplemental oxygen. Therapy beyond several weeks, however, is not known to improve outcome and places the child at risk for electrolyte disorders. Adequate caloric intake can be difficult for many reasons, including oral aversion, discoordinate suck and swallow, GERD, aspiration, and aspiration with GERD. In addition, tachypnea, episodic respiratory distress, increased work of breathing, and requirement for supplement oxygen place the infant at risk for growth failure. A high caloric intake is necessary, with ranges of 120-160 kilocalories per kilogram day required, frequently in combination with fluid restriction. To provide such high caloric intake in the compromised infant, supplemental feedings through a nasogastric or gastrostomy tube may be considered. Careful attention is necessary to maintain fluid balance. Gastroesophageal reflux is common and must be suspected in patients not showing response to therapy and in patients with frequent exacerbations, especially exacerbations without clear triggers. Definitive diagnosis is necessary because these patients will be subject to prolonged promotility and antacid medications. Appropriate anti-reflux therapy in infants with GERD decreases respiratory complications. Gastroesophageal reflux with pulmonary aspiration or aspiration alone may manifest as chronic chest congestion, wheezing, and episodic hypoxic spells. Fundoplication with a gastrostomy tube is performed in patients showing no response to medical therapy. Evaluation and treatment by a speech therapist, pediatric pulmonologist, or otolaryngologist may decrease the risk for development of chronic lung disease associated with aspiration. Prevention of respiratory viral illness is vitally important. Frequent hand washing by caregivers, especially before they handle the baby, and avoidance of contact with children and adults with current respiratory symptoms are essential. Respiratory syncytial virus RSV immunoprophylaxis should be considered on the basis of the severity of lung disease as well as the patient's gestational age and current age. The prognosis for infants with BPD is generally good. Through school age, the family can expect frequent medical interactions for episodes of respiratory distress, commonly triggered by simple upper respiratory tract infections and weather changes. Pulmonary function in severely affected patients remains decreased, and exercise limitation may be present because of dyspnea. The most severely affected patients benefit from care administered by a multidisciplinary team of caregivers, including the pediatrician, pulmonologist, speech therapist, nutritionist, and developmental specialists.
Well, I'm Josh Bloom. That's my wife, Amber Bloom. That's our son, Jackson. Jackson was born at 23 weeks, 5 days, so very premature.
Everything seemed like we're getting everything set up to stay there for the rest of the pregnancy, and he decided that wasn't what he was doing. They were getting a medical staff over from Children's to take him immediately once he was born. Very, very scary, not really knowing what was going to happen, where, you know, we knew that he was going to be about a 1 pound baby. I think having a baby, that's all you're going to do is hold him and snuggle him, and we just watch ours lay in a little incubator. It was amazing getting to hold him for the first time.
All your, sadness or whatever is gone because you're so excited. I spent the first basically 9 months in the hospital, and since then we've been at home.
Probably a week to a week and a half before they came with boxes and boxes and boxes of all this stuff that we were going to need, possibly need, maybe not even need, but just to be on top of things. And then the day that he came home from the hospital, they came to the hospital, brought us home, make sure we got home, made sure everything was set up, running in order.
Once you bring him home, it's just a completely different ballpark. It's a little bit overwhelming on how much stuff, you're responsible to having in your house.
Once a month, they're out here, sometimes more.
I'm Alyssa, and I am Jackson's respiratory therapist, and I come out once a month to do his equipment checks, and I do what is called an end-tidal CO2.
PHS rocks.
PHS rocks. We always know that they're there for us.
As crazy as it sounds, this is almost our norm, We've been so blessed with the services we've got and how well he's progressed. We look forward to no longer having the trach come the 26th of July.
He's our strength. If he's gonna fight, then we're gonna fight with him.
Yeah.
Thank you.